good afternoon for this afternoon sessions. I'm sure all of you are well fed, and if you are still awake or keep yourselves awake, I invite you. I'm sure Vivek is going to keep us all awake. So, Dr. Vivek Jain has done his MD Pediatrics from Yogesh. What did I say? Oh, Vivek. Sorry, I'm not sure why. Okay, so I'm overfed and all. So, so Yogesh Jain has done his MD Pediatrics from AIMS New Delhi, and but is a public health physician in practice. He has been primarily involved in primary health care through founding and running community health programs in rural Chhattisgarh in central India since 1999. He has been involved in understanding the political economy of illnesses and addressing technical and political issues that determine the health care of the rural poor through clinical care, observational research studies, training, and direct political work based on lived experience. He is a strident believer in the state as a primary provider of social services. So I would invite Yogesh to come and deliver his talk.
Thanks, Samuel, for this. I speak as a person who's trained as a clinician, but a specialized clinician at one way, and with some initial time spent as an academic for about a decade, and then the next 2.5 in as a public health physician. And what I am going to discuss with you, all of you, is based on experience of working both the level of in the community, as well as where I started my journey in healthcare, and thus I also dedicate this small discussion to my first mentor, who at least initiated this understanding about health inequity, Sushil Kabra, who's professor of pediatrics at AIMS and now retiring the end of this month, from whom I began this journey. And so can you move this first slide? So, we've been using this word equity rather frequently since in the last 1.5 days. I want to get in the word injustice, because usually inequity is a consequence of injustice in the distribution of health of resources. And I think all of us, while living and while working, both in an unequal country like ours, in an I would say an unjust country for many people, have been seeing stark examples of and levels of inequity in healthcare. I don't think that has missed that we have missed seeing this in our work, in our lives. And at some level, we also have an understanding about why this inequity happens. We know that it is largely because of the large proportions of people are poor, some extremely poor. And we also know this for a theory point that inequity happens across multiple axes, whether it's the caste in India, gender, geography where you stay. Actually, one of the most important risk factors in which determine outcomes in health is where you stay, whether you're staying in a rural or an urban area. Religious identity, social category, and sexual identity, for to name a few. And we know this word from people who have worked on this work, that a lot of this is structural violence, as opposed to obvious violence as you see in what you may be seeing in Manipur, but structural violence where it's embedded inequity, which determines your outcomes. So I think the point that was brought out yesterday, and I would like to classify this further, that knowledge production for which in healthcare for particularly is actually undemocratic. we are not asking the right questions, and therefore we are not also finding the right answers, is an allegation that I would make, and I would exemplify it later. And you hear these, which leads to these ideas that people have, which many of us in healthcare also live with, that these tribals are always drunk and alcoholic. I heard this phrase so frequently in working with visiting communities, कि ये आदिवासी लोग तो हमेशा दारू पी के पड़े रहते हैं. This is and I've heard people who are in development sector also speaking up such phrases. Or we can't understand why people come in so late, and with high levels of sickness, and why can't they come in earlier? This is a question I've heard so many medical students, as well as junior health workers, junior residents, and talking about and wondering in almost, no. And this point that I've seen in some nutrition program that keep on running, when I ask many people, why do some people have poor nutrition levels, and they say the most important reason is poor education, poor knowledge of what to eat and what not to eat. I think that's such a lot of nonsense. And this question, does health and nutrition education improve nutrition practices and nutrition status among the poor communities? I would seriously doubt this point, and I think the answer is no. But yeah, but a lot of people believe that with just nutrition education, you can improve the nutrition levels of people. And this debate also happens at another level, whether we should give cotrimoxazole or amoxicillin. Debate happened between people, whether because on the specious grounds that cotrimoxazole is cheaper, and whether life was not cheap or something. But this was the thing, that these are the myths that that which flourish because I think the knowledge production has been undemocratic. So and then I pose this thing: if we know about these logic about inequity and injustice, why is it that we don't see inequity playing in our clinical work so easily? Why do we need even a discussion like this, where I have to preach in a sense for how to pick up inequity? And I would say this thing in an old saying, but the eyes don't see what the mind does not have in its perspective. We may know the theory bit of it, but it's not in our perspective. And I can even exemplify one thing that I failed also. I claim myself to be a champion of hunger and nutrition, and I know that Adivasis have a poorer nutrition level. This is borne out by data that is coming out. And I had a visiting health economist. You might have heard his name, Jean Drez, who was with us, and I was taking him into some areas where we work, where there were people from particularly vulnerable tribal groups. And I told him, these are the people who are a particular group called Pandos in northern Chhattisgarh. And they're among the poorest. That is a thing that I was sort of telling him. He said, of course, I can see it. These guys are 6 inches shorter than any other men in this area. And he just pointed to the other side. And I had missed this in my observation, that these people were, the average height of a Pando men is 5 feet, as opposed to 5 feet 6 inches for the non-Pando tribals. And I had missed it because it was not somehow, I had not lived this undernutrition in a sense, and thus I missed it. So, and I think the other reasons which I want to point out about why don't we see inequity playing in our clinical work is our busyness in the clinics. The amount of time that you spend per patient. Say you ask a resident or a doctor to see 50 patients in, say, 4 hours of a clinic. You're spending, less than 10 minutes per consultation, where you have to do everything from reaching a diagnosis, from asking questions, to writing, to reaching a diagnosis, to examining, and finally advising the next, making the disposition for this patient. You will not be able to look at, and you assume that there's a pecking order of importance of what you are supposed to do as a clinician. That first you're supposed to biomedically diagnose, then you look at those so-called softer bits about it, which often get ignored because the clock runs out for the next patient. And this is a real problem. And I've seen people who say, I cannot see more than this number of patients in a particular time. I don't care who sees, but I can't see. But this is not a choice that most of us can make in our clinics. And so this is the pecking order of the bioscientist. We first biomedical diagnosis, then we sort of communicate. This is the next level of importance. But social determinants is something that is in a pecking order of importance of for a clinician comes at number 3, and that's why we probably miss discussing about inequity, and it is a thing that is sort of dispensable. So I would therefore now go into the second bit of what I'm going to say. So what do I propose? What are the ways that we can learn to pick up inequity in our work? And I have 5 suggestions. I'll go and I'll mention those 5 one by one. And then in the next third phase of my chat, I will talk about using some examples from my own lived experience about how I went about looking at inequity from what I did. So these 5 strategies include the first, which I want all of us to hone this skill if we don't have it already, is of active listening. Not just hearing, active listening as a skill, which I know psychiatrists develop it to a fault, but I think all others among us as either domain specialists or as generalists or but we should spend time to acquire this skill if we don't have it, and also to verify whether we have the skill. And the requirements for that, if I may sound a little preachy, one is to be unhurried. Even if you're giving 3 minutes to a patient, when you're talking, when you're hearing, then those 3 minutes, the world should stop for those 3 minutes. No, it's not that you are picking up a cell phone or listening to what is your resident is doing sitting across your table, or someone else who's clamoring outside to enter your OPD. That time is unhurried time for both speaking and listening. And so with the 100% attention, however that is done, and not only listen to the voices, but also to the body. This is something. So active listening is not only from your your cochlea, but also your eyes and rest of your other sensory organs. And try to make your speaking not more than 1/4 of that transaction that you are doing. 75% of time should be for active listening in your transaction period, and asking open-ended questions, which is a difficult thing for most healthcare worker that I've seen. We are used to hearing our own voices so much and asking direct questions, and we have assumptions that we want to just ensure that these are coming through. But asking open-ended questions is a thing, and you will make much less mistakes if you do this skill. So I would say these 5 sub-components of what I call as a primary skill for someone to pick up health inequity, to learn active listening. My second suggestion, which I think Emmanuel Lazarus mentioned very beautifully yesterday, is to get into lived experience. Most of us, let's face it, health workers are from a different class. So for us to pick up the consequences of inequity and injustice, it is something that we'll have to learn. Most of us have not had that experience of acquiring it in our socialization of learning. So we need to have this experience, for which we'll have to make efforts. It cannot come from reading books. So you'll have to live that experience. And the minimum that you can do is first to associate with mentors and associates and others who work with the marginalized. Do this. So even the ecosystem that Anand has created in these 3 days, I think, is one such. But also with the people who are here, to engage with them in your future learning process. And I propose this at least a 2% model in life, in a year. So 2% was about 1 week in a month, in a year. So can we spend 7 days in a place where people who are suffering the consequences of health inequity and injustice, you stay with them? That's the minimum that you have to do. You can make it 4%, that will be great. And or you spend your entire life is okay, but that I'm not sort of being as harsh as I was yesterday, but this is what I would say. This is something that we would like to do. So lived experience, and there is no other way. You cannot get that thing without having this lived experience about learning about. Um, and the third suggestion is what I want to get into this, you know, respect questioning and indulge in it. Um, and don't make assumptions about, or make it as little as possible. Obviously, we'll make some assumptions, but try to make as little as possible. If you don't understand a thing, then it's best to ask a question. So I proposed it that by, Krupa was there. I was asking, why did this woman, 21-year-old girl yesterday have tuberculosis? This question has to be asked. So, or for us, similarly, there'll be many more questions that might come up. So please get into the idea about questions. And as I said, I've often said, questions are clearly more important than answers. Because, we can, if we ask the wrong question, then we'll obviously not get the correct answers. But if you don't ask the right questions, then you at least have an possibility that you might get the answer. You may not get answers very easily. So ask why for everything. So if a person is, coming late to a clinic and in an advanced stage, ask this question, and then ask causes, as Harsh was telling about causes of causes is something that we should get into the habit as, as public physicians, that we need to pick up. And I would even say teachers should pick up this question about, asking whys. And also, this question you should ask to yourselves when you are comparing and when you're getting angry or getting irritated about a particular thing. What would you put yourself in that position of a person's decision or observation? What would you have done if you were in that situation? Ask this question each time, because in this case, the feminist word about personal is political. I think this is actually the most important thing that you would need to do when you are working with other people as patients, or as, as in the community. What would you have done if you were in this situation? That the person, the incumbent is in to ask this question. And my fourth suggestion is largely for medical college teachers as well as, program managers. Please, this is a proposal that I want to make. Please, at least once a week, have social medicine rounds. These are not biomedicine rounds. These are not to fix the diagnosis or to plan the treatment, but to understand the consequences of injustice in health. And that's a great learning thing, not only for the students that you are going to be, working with, or your nurses that you're working with. I'm talking about yourselves. You'll be the greatest learner in this. So at least once a week. And the focus clearly, you're not looking at getting the correct medical diagnosis in this case. And why can't have humanities trained person, if you're not yourselves trained in humanities, join the rounds? Why can't it happen? And I think the entire team, including the nurses, and I would say the entire faculty of that unit should be there if it is in a medical college. But otherwise, if you're in any other hospital, then most people should join, so that the power of conferring and thinking together will come up, will also be harnessed. And don't take too many. Suppose you have a clinical ward of 20 patients, discuss only in 4, so that you spend enough time and spend about 2 hours for discussing four clinical situations, so that it's more of a learning exercise. It's not so much as a service exercise to run social medicine rounds. And I take the liberty to offer that if any of your units want to do it, I can at least, I offer to show it once to do how it can be done, though I'm sure many of us can do it as well or better, over time. But to make a commitment for social medicine rounds, and as I said, everyone to attend. So after these suggestions, I'm going to talk about 5 issues in my lived experience where this practice of asking questions, of active listening, of of conferring together in a social medicine round, and having this lived experience, I've been able to understand health inequity, and through this, I would say, why don't you take a leaf out of that? So we know that, this data, there is a lot of theoretical data that shows that for an 8% of population has 70% of falciparum malaria. That's the tribals in India. And if you, those of you who have worked with tribals, have visited or have stayed with tribal families of people, you would know that that they have all the things that go against their being healthy. Um, but we have seen the national vector-borne disease control program before. What was this? The malaria control program. Hello, can you? So the diagnosis was largely clinical in the national program. And there was rampant misuse of drugs. Dr. SP would tell us in mid-70s, there used to be inland letters which used to have this phrase, koi bhi bukhar malaria ho sakta hai, and everyone was given chloroquine. And smear was taken, the report of which would come in 2 weeks' time. And it was it was not supposed to help that patient, but to have some epidemiological data. I don't know whether even a data was even generated. And there was no trust in diagnostics. No one trusted it. No one gave a damn to the report, because no one, either the reports wouldn't come or the reports would not be important that time 2 weeks later. So, and severe falciparum malaria care was in big cities, whether it is dialysis, whether it is in transfusions, whether it was intensive care, far away from where most people with malaria had. And the surveillance systems were basically for positive smears in public systems. It was not meant for patient care. So we asked this question: is it possible for a person who's living in an off-the-road village to get a report for blood smear for malaria in good time? Good time in malaria, falciparum malaria, would be less than 24 hours, correct? So we asked this question, and then we sort of found solutions to that, and that is what and can we prevent overdiagnosis, and can we also monitor if there is emerging drug resistance, which you can do in malaria, if you know, by doing a smear on day 1, and on day 3, 72 hours later, if the parasites have disappeared, that means there is, this is a drug responsive malaria. If it is not there, if it is still more than 25%, then you say resistant malaria, which is a worry that Dr. Aquinas was talking about yesterday. So, and therefore the role of the laboratory came up. Most of us public health people give a damn to labs, but we know that without labs we cannot really do equitous medicine. So if the lab, because the labs are supposed to be machines, a lot of trained people who are going to be sequestered in more high resource areas. So if the people have to come to the lab, but can the lab go to the people, was the question that we would ask. And we could avoid shotgun therapy and use technology. So we trained our health workers to make blood smears. Why not? This was about 20 years ago. So they could make blood smears, fill it in pictorial form, so that even if they were not neoliterate, they could send forms. And these could be taken, because of the lack of transportation of these smears. If you could even take microscopists to the village, so you could take these children could, the high school children often go to the main road for collecting for their education. So can they take these blood smears and send it to buses, which usually in most of rural India go from rural areas to urban areas in the morning hours, and they come back to the cities come back to the villages in the late evening. So the smears would be picked up by when they reach a hospital on priority, reported, and the correct instructions given, and then these smears would go back to by the time they would reach the school, by the time the children are supposed to go back home to their schools, to their homes, and they would take the reports and give it to the health worker. You can monitor, you can treat adequately, and you can avoid giving antimalarials to those who don't need it. So this was, looking at the iniquitous thing about a laboratory in case of one of the biggest killers in the recent past. Now we have scrub typhus. We'll talk about it later, and we could also monitor that, this myth that malaria is a disease of, rainy season. I think it's such a lot of crap that has been spoken in it. Malaria is a disease of after late monsoons or early winters. In central India, at least. I can't say this for the rest of the country, but malaria is basically a central Indian disease. It's not a disease or northeastern, maybe. And now, and we realize that the peak of malaria is in November. If someone had told me this as an academic in Delhi, I would have, if a resident had or a student had told me that malaria is a disease of July, I would have, failed that person maybe at that time. I don't know what would have people have done below now, but so I would go to this second observation thing. You need to look at things. So this was this young, this is a middle-aged gentleman who was 52 years old, and he came, and in the hospital that I worked, one of the ways we listen to is we take everyone's weight every time. So, and even in the so in and that's probably a legacy of the pediatrics that I learned. But I think we all do weights of everyone every time. I don't know medicine department of CMC does weights of everyone every time. I'm not sure, Samuel, but you can answer. But we weighed this person who was obviously looking undernourished, what is called in clinical pediatric severe no. No, there is another word, no, that which you look. Hello, sorry. Oh, okay. 28 kilos. So 28 kilos weight was this of this 52-year-old person, and we realized that tuberculosis in central India was malnutrition first, diabetes next, retrovirus number 3 as a cause, and MDR TB was nowhere to be seen. That was what we realized. So rather than have this thing about the Bombay experience of 22% being MDR is not the experience in central India there. And these were the bodies that one saw of a family of 3 who had tuberculosis together, the father, son, and the daughter. And this data that we looked at, and this is also a part of listening, the median weights were 42 kilos in men, and the median body BMI was 16. 52% people had BMIs lower than 16. 88% had BMIs lower than 18.5. With this situation, what are you thinking about? Giving anti-tubercular treatment is going to be enough. So, and we knew that nutrition undernutrition is associated with all the bad so-called outcomes in tuberculosis. And even if you look at the data, the undemocratic nature of data management, the Madras trial, the famed Madras trial, had shown that people who were in sanatoria and those who were not in sanatoria, they both had equal microbiological outcomes, but their weight gains were completely different. 2 pounds in a home care person, and 11 pounds, 5.5 kilos weight gain in a person who was in a sanatoria. And we know that weights as outcomes, weight gain is an outcome, a long-term outcome, the role that it plays. So we realized over this thing that basically illnesses are biological embodiments of inequity and justice. I made this joke yesterday about the X-ray showing poverty, but actually this is what we need to learn. That yesterday's patient could be clearly any ass would say it is tuberculosis. It didn't require a doctor to do that. But what is beyond that? Why this? What was this tuberculosis due to? So we got into this idea about food and TB. This question came up. So and this is one thing I've realized. There's a lot of adult medicine doctors here. Adult undernutrition is something which is whitewashed. As I say, as a disclaimer as a pediatrician, when we talk about undernutrition, suddenly the imagery is of a child who's undernourished at 9 months or 12 months. Do we look at adult undernutrition as a larger problem, because there are more adults than children in this world? So, but we don't neither talk about it, neither we feel that it should be a priority for management. And we have sanitized the word hunger in this process and call it malnutrition. So, Dr. Nihal Thomas is not here, but I want to get on to this third thing about phenotypes of illnesses. So I would posing this question, do we study the illness phenotypes well? And I want to bring up this curious case of lean diabetes that we see in central India. So this is a young person called Jeturam Uike, who I had been seeing for 10 years. He had lost 1 unit point BMI from 17.5 that I saw him 10 years ago. In 2013, he came with a BMI of 16.5. And he came with a cough of 1 month's duration. The waist was 65 centimeters and the hips were 81 centimeters. He was sputum positive and then detected to have a blood sugar of 560 milligrams. He was slow in responding, but he required metformin and insulin for diabetes control. And the question that I asked is, why did he get diabetes? Why should a person who's a BMI of 17.5 for 10 years get a diabetes? I had learned from my books that diabetes is a disease of the obese. If you look at American data, over 90% people are obese. And this person didn't even have that neo obesity. Even the waist hip ratio was also was okay. What was a faulty lifestyle that he had led? We use this word lifestyle so liberally, as if you want to say that this person is sitting in a bed and watching a television. Uh, um, and there was no tobacco that he consumed. There was no weight gain that he had acquired over this thing. He was working every day of his life till he was unfit, and there was no HIV. And when we looked at it, we found that his oil intake per day was only 11 grams per day, and there were no fruits, which doesn't mean anything. So we realized this, this enigma, this phenotype was 80% of diabetes that I see were low in body weight or normal body weight, either way, and half of them would be low body weight. And this is behaving somewhat like type 2, but not exactly like it, not even type 1. So malnutrition modulated diabetes mellitus. Majority occurring in hard-working poor people, poor peripheral neuropathy and infectious complications being common, and very often require insulin at the beginning of the treatment. So, and these weights were the weights that one hears about in Holocaust situations. So lean diabetes is a thing that has not gotten the importance from the world of us academics. The International Diabetes Association does not even have this word. They had it for 5-7 years during the 1990s, and then they dropped the name because they thought that it's not worthy of. So these require 50% require insulin soon, and sugars are sky high, and it is not FCPD and not a delayed presentation, not type 1, type 2 diabetes. And what do you advise is for these people? Should I ask them in a country where rural people consume 92% cereals, that they should eat less cereals with a weight of, with a BMI of 16.5 now, and to do some more exercises or to do yoga, as we have learned, and, or eat less. So actually the question that came up was, why can't we look at how poor people live and how they die? So we need to understand this phenotype of diabetes, and I learned that the Department of Endocrinology is doing very actively trying to understand this in Vellore. They need to come to Central India also, ascertain the nutrition and associated causes of lean diabetes, and how to organize insulin delivery to people in remote tribal areas. What food advice to give to people who depend upon the PDS. So this was the third point, and if you have time, I'll take 3 more minutes to talk about 2 other ideas, but I can, or should I? So access to drugs is an issue that we realize. We are all taught pharmacology, even including, all doctors and nurses are taught pharmacology, therapeutics and pharmacy skills. I know we remember triturating, Whitfield ointment also. But are we taught about the prices of drugs? Anyone, does CMC Vellore in the pharmacology department or medicine department teach the students about the prices of drugs and how the drugs are produced and marketed? I don't think so. Prices, are you teaching? Wow. So this is, I think we should all, learn from CMC in that. We know that 70% of the cost of healthcare is accounted for by drugs. Thus, purchasing drugs for care is a cause of impoverishment and indebtedness. There are studies to show that. So I also realized when early in my work that 35% of deaths in 2003, when I'm talking about the year that I did verbal autopsies of everyone, did not consult anyone for the cause of the illness that killed them. Because the scare of medical indebtedness and made people scared away from, seek people abandoning the health system. And that was a time in 2003 that the prices were getting decontrolled. That it had just come up, the order, then the draft pharmaceutical policy then. So, and then, we realized that people had taken a lot of loans for this. So, and we had compared prices, no? Telmisartan, in a hospital like ours is available for 1 rupee 30 paise. I'm sure in Sevagram it is much cheaper because you require a higher purchase rate. And in TNMSC it must be even cheaper. Amoxicillin is for 2 rupees against the market price of 650. And there are prices are very different. And carbimazole for 70 paise against 4 rupees in the market. So drug pricing showed that TNHSP has been able to, TNMSC, sorry, not HSP, has been able to provide drugs to people at prices they could negotiate. And so, for example, albendazole as a drug, which is available in the market for 14 rupees, we could get at 1 rupee, so-called Sevagram, and TNMSC gets at 22 paise. This is, and I'm sure the person who's selling to TNMSC is not giving it as a charity. He's probably also making a 10% increase. So they must be producing at 20 paise and then making 22 paise from this thing. So we then understood how drug pricing is done. That's an act that all people who are interested in health equity should be doing it, and how it should be done. And we filed a PIL in the Supreme Court in 2003 and got a stay on the draft policy. And even though the the formula is not the best, but at least all essential drugs are now under price control per the order of 2017. So, and my fourth thing is about, for the surgeons, if I say, we talk about primary health care. We know that when there is no doctor, there is often no nurse. This is also true, or there are places where there is no doctor but there may be a nurse who stay there. Usually not, but yeah, but where there is a doctor, there's no surgeon. This is a. I'm sure many of you are surgeons who do medicine work, but there are very few places where people who are doing medicine can do surgery, because it's the best definition of a surgeon was once I was told was, a surgeon is a doctor who's a medicine person who can operate. So there is no surgeon in many places. And when we looked at data over a full 1 month, I realized that surgical problems are a significant component of problem. But surgery has remained a stepchild of public health. Even though we know that so many people require surgical care, a pediatrician or an internist or a community medicine person getting into the community is easier, is commonly seen. But a person with surgical skills, they may be running mission hospitals, but they're not into the into community work so easily. But we need surgeons, and surgery will require an institution. So finally, I would like to end by saying that we need to all, while talking about equity, we need to work on knowledge production. And asking the right questions, as I said, was more important. Then deciding on how to find the right answer. Then analyzing the answer and having a dialogue with others. It's not just that you find an answer and then you say, forget it. Discussing, and meetings like these are very important, I think, where we can discuss about answers. And I think, Anand, I would say this, you should hold it annually if you can, if not biannually. Asking the right questions is important, and I can just pose some of the right questions that I have come to my mind. What is the pattern and burden of disease that tribals in India suffer from? We don't have an answer to this question even now. What is the healthcare package that they should be available at each level of health facility in tribal areas? And tribal areas means not only for tribals, but people who are non-tribals also who are staying in tribal areas. There are many questions in malaria, tuberculosis, and leprosy that are still unanswered, technical questions. Food and illnesses. Which other illnesses you should be giving supplementary food rations for both the person and for the family? Why don't we have price control? We now have this answer to this question, that we don't have a good price control, but we have a price control over our essential drugs. Should tertiary care be supported for tribals? How should we handle NCDs among tribals? Is there any merit in conditional cash transfers, or should we just throw it out of the bin? Is institutional delivery model the only way to look after childbirth? And what is the best way forward for human resources in health for tribal areas is something that I would still pose. I would end this by saying that, This work about working in, this work in working in health, getting health equity, and is a work of for health justice, and I think justice should prevail. Thank you.
Thank you, Yogesh, for your presentation. I have one quick question by Dr. Anil Cherian. As a clinician, having listened to your patients and having a lived experience, how do you struggle with the root issues, structural violence, corrupt economic system, the social determinants? How do you deal with the frustrations and anger? What personal resources that you have? Gandhi saw it as an internal spiritual battle. Would you agree?
I think the answer would be the struggle has to happen. You cannot give up, is the thing, because there is no other way but to continue struggling. And I would say, not just to see it as a spiritual thing. I think this is a this is a this is a this is a quest for justice, and I think we hold justice as a primary mooring for, our for our for any systems, in our case health systems, um, just to struggle for that. And I personally derive a lot of satisfaction or sort of courage from the lives of the people who live off the land. The struggle that they have to do is far more that I have been involved in, or I get involved in. So if I just look at it, if they are struggling, why not me? Though being hopeful for victory is something that is should be tempered still. Yeah, Ravi is.
Thanks, Yogesh. It's been a very interesting presentation. And I'd like to expand on one point that you made about social medicine rounds. I think that's a very important thing. And I think as part of, if you want to do advocacy on improving, say, the sensitivity or training of doctors, then it should be part of a continuing medical education process in terms of getting, say, sending doctors, whether they work in the private sector or so, you make it as part of your CME, whatever minimal requirement for renewal of license, and they go and live in a deprived situation, go to remote sub center and work there for a week or 10 days or whatever, or in a tribal village and so on. I think this sort of a thing will definitely send in the NHS, the Director General or the Surgeon General of UK. He devotes clinical time. He goes to a dispensary or a clinic and works for a certain number of hours. So something like that, I think, and I think that's an important point that you made.
Thank you. Any other questions?
We have many, several teachers from,
Yeah, go ahead.
I don't have a question, just an observation. Living in a rural area, the structural violence that we perpetuate is something that I observed at this stage. Ration shops, schools, and panchayat office are all based only in where caste Hindus live. So the power structures have to be with them. And this becomes an obstacle for me. If I ever want to conduct an awareness program on suicide or mental health, will the most oppressed be able to come? What is there? They may be in other days mixing here and there, but this whole venue will be only here. So what do I do? That's a dilemma I have.
I have no answer to this. She didn't say, it was not a question. Yeah.
Okay. Any other? That's a good way. Any other questions or comments? One comments Anil said, surgery was included in the WHO primary healthcare package in 2016. primary surgery education is being done in Africa. However, there needs more policy changes to allow this in India. Opportunity for advocacy.
Yeah, we make good documents. WHO also does good documents. You know. No, there are many. The Dr. Makunda's hospital, Dr. Vijay. No, he's a. So there are so many. You know, a lot of these mission hospitals are run by surgeons. But I mean, I'm not talking about surgery as a part of the entire thing, not just.
So, thank you, Yogesh, for your wonderful presentation. I think these are not that we discuss; these are something that we internalize and reflect and see what we need to do about it. I think there's one word I would leave our entire group with is a lived experience, and I think this less than 2% model is a excellent suggestion for us to quietly reflect on. Make your individual commitment at some point of time to spend that time, let things sink down. You may not have answers. They aren't really great answers for the issues that happens, but going through it may sensitize us, and hopefully some answers will come somewhere. So thank you, Yogesh, for really stimulating that thought. Really appreciate it.
Dr. Yogesh, I request Dr. Samuel to present the memento.